adjuncts, dyes, and all the flap maneuvering techniques we see these days in simple and as well as complex cases. The objective finally is to make it clear that no single technique suffices for the various surgical challenges in macular diseases. We have a galaxy of speakers here, and because of some parallel commitments, we'll like to shuffle the sequence a little bit. We'll start with Dr. Bhuvan. He's a senior vitreoretinal consultant in Bharti Eye Hospital in New Delhi and a prolific VR surgeon. He'll be speaking on optic disc pit, case-based presentation of various management techniques.
So a very good morning to all those who are here, and I would like to thank Vishal for including me in his course. And he's a very dear friend, and he was my junior in RP Center, and we have got many associations together. So I just start with my presentation. So I am talking first on the management of optic disc pit. So this is a very rare entity uh, which we encounter in our clinical practice. It is a congenital abnormality of the disc, and it mostly involves the temporal side of the disc. It's very rare, as I said, and in 10 to 15% of the cases, it is bilateral. In most of the cases, the patients are usually asymptomatic, and it is just as an incidental finding, or a patient may present with a optic disc pit maculopathy, which causes visual deterioration. It is associated with the presence of subretinal fluid, macular schisis, that is in the form of intraretinal fluid. So this can happen in about 25 to 75% of the cases. So the main problem in this is the pathophysiology of the fluid. From where is the fluid coming? Whether it is coming from the vitreous cavity or it is coming from the cerebrospinal fluid. And hence there are controversies in the management also. So initially, if we go back by history, they used to do a laser along the temporal side of the disc, but usually used to stop the progression of the fluid. But however, it can also be associated with some tissue damage. Then came pars plana vitrectomy with laser and with gas tamponade, and now we have come with the concept of doing a foveal sparing ILM peeling and plugging the pit with different sorts of things. It has just become like a dumping bag. So is it really required or not? So this was one of the initial videos which I of optic disc pit, which I operated. So this is the most important step I think in a management of optic disc, that is the induction of PVD. Usually it may be associated with vitreous schisis, so it's always better to use a triamcinolone to while inducing a PVD, because it's also difficult because of the adhesions around the disc as well as presence of vitreous schisis, as can be seen in this case. You may need repeated attempts, may need a forceps also to grab it, but once you have an opening, usually with these 25 gauge cutters, you can go very close to the retina and you can just induce the PVD. So this is the most important step, since it reduces the traction at the area of the disc, and most of the cases will resolve with this simple procedure. So just I wanted to highlight that inducing a PVD is sometimes difficult in these patients because they are young. There is presence of vitreous schisis. So just induction of PVD. Another important step is just it's very important to screen whole of the periphery before ending the case, because in this case there was a peripheral lattice degeneration with a break and a localized RD, as you can see in this hole which I just cryed. So another important step for all VR surgeries, you have to do a screening at the end of the periphery. Otherwise, it can lead to a failed surgery or a retinal detachment post surgery. So in this case, as I said initial video, I did a mild sub-threshold laser, which is not visible at the margins of the disc, which has got a very controversial role. So this is the pre-operative pictures of the OCT, and these usually take some time to resolve, so you don't have to just hurry. Gradually the OCT pictures, it improves. As we can see, the vision is improving and the fluid is also going off. So as we can see, the connection from the optic disc has gone, and this fluid, I don't have the latest OCT, but this fluid had also disappeared and the vision improved to 6/12 in this patient. So you can see that the fluid coming from the optic disc, this area has flattened out. So, do we have to do ILM peeling and the plugging of the pit in every case? So, that is the main controversy. So, initially, as I said, 10 out of 11 patients in a study which was done, it showed that vitrectomy with gas exchange without endolaser photocoagulation reported very good successful results. Some authors, they propagate the use of some subthreshold photocoagulation at the temporal side of the pit. It They say it creates a permanent barrier to prevent the fluid leak. So if you use a very subthreshold mild laser, it usually does not cause tissue damage and may also increase the chances of the success rate. And studies have shown that they do not cause affect the central visual acuity. Probably they just cause enlargement of the blind spot. So this is another video in which I did ILM peeling after induction of the PVD, which is the most important step. The ILM peeling should be foveal sparing because usually the retina is very thinned out and it can lead to complications like macular hole. So I'll just fast forward this video a bit. So after induction of the PVD, again injecting triamcinolone is a very good idea because you will be able to see the vitreous, as it is difficult to induce a. So this is a foveal sparing ILM peeling was done, and one of the pieces of the ILM was then plugged into the pit. Okay, so I think now the message is clear. So this was a patient who had a vision of best corrected visual acuity of 1 meter, and this was the optic disc pit with in macular schisis, presence of subretinal fluid. But what happened in this case, this video I'm highlighting because despite a foveal sparing ILM peeling, the patient developed a macular hole, and the vision did not improve. But however, the near vision improved, and so this is the problem which we can have while doing an ILM peeling. So again, as I said, since the pathophysiology is a controversy, the management is a controversy. The fluid can come either from the vitreous cavity or from the cerebrospinal fluid. So the main cause is vitropapillary traction. That is, the source of the fluid is from the vitreous cavity. If the fluid originates from the subretinal fluid, then probably going beyond a PPV is suggestible, like doing a foveal sparing ILM peeling or the plugging of the pit. Otherwise, it is not required. So as I said initially also, the pit is now like a dumping space. You can put a lot of things into it. You can put the ILM. Some of the reports are there of putting amniotic membrane or fibrin glue or an inverted ILM technique. So these are all the techniques. So again, the controversy is whether this is necessary or not. Both the techniques have demonstrated favorable long-term results. So I feel that PPV should be the first line of treatment, and if it does not succeed, then probably we can go ahead for a surgery like a ILM peeling with ILM plugging of the optic disc pit. So this is one video just to highlight that most of the cases, the problem is originating at because of the vitropapillary traction. And as you can see in this video, the vitreous was very tightly adherent to the optic disc at the site of the pit, just indicating that the main reason is because of vitropapillary traction, and the fluid is most probably coming from the vitreous cavity only, and hence no need for plugging of the ILM. So another video just highlighting the same thing. So this I'm just showing in a slow motion. You can see that the main traction, you can see this gliosis and fibrosis present at the temporal margin of the optic disc pit. So hence, when I see this, I probably decide that I will not do much for this patient. I'll just do, I'll keep it simple. I will do just a PVD induction, a PPV screening of the periphery, and injection of gas at the end of the surgery. So long-term outcomes without internal peeling have shown very good results. They showed that the vision improved to better than 6/12 or 20/40 in this study, and subretinal or intraretinal fluid was completely resolved in 12 eyes out of the 13 eyes. So just putting it all together, since there is a lack of clarity about the diagnosis, about the pathophysiology, there is no established guidelines. So in addition, the macular fluid, as I said, it's not known from where it is coming. So the gold standard still remains as a primary procedure, I think, is PPV with PVD induction. So that will prevent the complications like I just showed, resulting in a de-roofing of the fovea and macular hole formation. And ILM's plugging of the ILM is only beneficial in a selected cases, in a selected number of cases. So one of the main concerns that should be addressed is the in a plugging is also the damage to the optic nerve, the mechanical damage to the optic nerve and the neurosensory retina because of the surgical trauma we are inducing by stuffing things inside the pit. So So just to conclude, PPV with PVD induction has a very high success rate of 90%, and these adjuvant procedures of peeling of the ILM, foveal sparing, and closing of the pit should only be done when the primary surgery fails. So thank you all for your attention.
Excellent talk, Bhuvan. So I understand what you are trying to say is that your preferred way of doing is of optitis pitis, just PVD induction and no peeling, and
Yeah.
with some augmentation of laser at the
Laser, I
margin.
don't know now. I think only PVD induction with a PVD induction with gas tamponade
You
as a
don't do
primary.
ILM peeling in these cases.
No, I don't do now as a routine
And
procedure since I developed that macular hole.
because of macular holes and a trauma to the disc.
The stuffing,
Yes.
yeah, that I will not do as a primary procedure. Stuffing, I'll definitely not do.
Can we have a mic?
There in any normal condition also, that may not necessarily be pulling the and causing a whatsoever. Whenever you do OCT in such situation, there is a definite shices there. There is a evidence that fluid is seeping from that pit towards that chytic cavity. So I know there is a controversy about what is the best for operating a pit, but something should definitely be done for that anatomical defect which is there.
So, sir, what do you think? A laser or a plugging of?
I'm not, I also, but I personally think whatever I have done, because numbers are not very high with me that I say that this is the best. Initially, we used to do laser, but my main concern is that if patient has more than 6/12 vision, I don't touch this eye at all. You see, all eyes with pit and with shices or this what is elevation in the macula should not be touched, because I can't give them from 6/12 to 6/6. Very difficult. So my take will be that apart from what you do, PVD, you should don't peel the ILMs. You have to take from ILM from the nasal side and put it over.
See, the natural course of the optitis pit maculopathy is also that sometimes we see chronic cases in which the fluid has resolved with a pigmentary change. And in all your cases, you said that the final resolution was in 3 to 4 months. Vis-a-vis, if you do a plugging, it might be a little traumatic. It might create macular holes in a minor set of cases, but the resolution is much faster. Aren't you concerned about the photoreceptor degradation that long term it takes to resolve in a simple PVD induction technique?
So,
I
Vishal,
agree. Some plugging has to be there.
so see,
More traumatic.
They will eventually resolve. The fluid will go away, but the duration is of concern.
I agree with you, but optic disc pit is such a rare condition that
Exactly.
probably we operate in
We don't
3 months or
have
6 months. We operate one case.
just one I want to add.
So,
In fact, I have done now around 12 cases, out of which 7 I have done with ILM peel and try to do that. But some theory is there is a kind of little bit of negative suction, because when we put that ILM across, they usually don't come out, and just with a gentle touch. And second thing is, I have even tried amniotic grafts also, and it sits quite good. And in my 3 cases of amniotic graft, it's definitely I have seen a good improvement, and the fluid is coming down. Although 2-line improvement I have seen, not much of visual improvement. 2-line visual improvement I have seen, but we have not compared with vitrectomy with these kind of the ILM stuff or the amniotic membrane, whatever we are doing. So I think if we have a comparative study, because as you know, sir, it happens 1 in 11,000 people, and numbers are less.
Because of the less number, it's very difficult to compare the 2-3 procedures, because we are not doing case every month or very commonly.
so thank you.
Yeah, so never do over the fovea. Always better, if you want to do an ILM stuffing, is do a fovea sparing and try to bring it to the edge. You can leave that ILM like a hinge at the peripapillar area and just stuff it. Or if it doesn't work like that, you can take the ILM from any temporal part of the area and try to stuff it. But the only thing is, you have to push it inside when you take a free flaps.
The next talk is by Dr. Lalit Verma, sir. He's the president of All India Ophthalmology Society. He is from Center for Sight, New Delhi. He is a former faculty in RP Center for Ophthalmic Sciences, AIMS, New Delhi. And he does not need any introduction. He's a teacher of teachers. We have all learned from him. I, particularly as a resident, since a resident, he's been a mentor, guide, and he has guided a generation of VR surgeons to what they are today. So I will be
Thank you,
presenting on
Vishal.
retrovacular traction and ERM.
Thank you, Vishal, for asking me to part of this very interesting course, and thank Partha Biswas also for giving us this hall. You see, VR interface disorders can be explained by the theory of anomalous PVD, where the vitreous gets liquefied, and but there's no complete detachment or PVD occurrence. So this classification, all of us must be aware of about VMA, VMT, and macular hole. Point to be noted here is only one, that focal and broad definition should be known. They may not be relevant from clinical point of view. But what is more relevant is about the small, medium, large, because in our scenario, everything is hyper large, in fact. None of the holes we get around 200 to 400. We get XXL kind of holes, so 1400, 2000 micron holes. So VMA is a condition of interface disorders where it could be a normal condition also, but remains adherent. This you see this green line here. There's no pull element involved. Vitreous is separated from the retina throughout, but it remains adherent. But there's no pull. And once the element of pull comes like this, what is shown here, then patient may have symptom. It is not necessary that all patients of VMT will have symptoms. So if this element of pull causes some disturbance in those three layers, ISOS junction and all, then patient may complain of disturbing metamorphopsia. Mild metamorphopsia, we may not operate at all. So there's always a discrepancy between what you see on the OCT, like this patient on the left side, because we had operated her fellow eye for macular hole, but this was an incidental finding because OCT is done in both the eyes. So vision was 6/6, although there is a huge pull on the retina. But since patient did not have any symptoms, and till date, after follow-up of more than 10 years now, this lady does not have any symptom. So there's always a discrepancy between what you see on the imaging modality and what patient may complain. But sometimes these patients of VMT may suffer acute visual loss also, and that is primarily because what is shown on the right side, upper side, because of this NSD coming up. So this patient, and this VMT, believe me, is very alarming. It's more challenging to operate VMT than operating a macular hole, because here the issue of heterogenesis, what Bhuvan was saying, may come in. So in such situation, we go round and round and do not pull. In a conventional macular hole, we pull vitreous with the help of suction very much. So although classifications have been given, frankly speaking, I do not pay much attention to this classification at all. V shape, J shape, or focal or broad, because from managerial point of view, it does not add any value to the our approach at all. More important is, do all this OCT diagnose VMT require intervention at all, or any change in approach? Answer is a very big no, because simply because most of these patients maintain good visual acuity and they have mild, occasional, or tolerable kind of metamorphopsia. And sometimes God may be kind that complete PVD may occur. And you see, like this example I had shown, right eye we operated for macular surgery, left eye this lady had VMT. Now the follow-up is more than 10 years. She still maintains 6/6. And this example is to show that this vitreous got separated spontaneously. You see, in this eye as well as in this eye, and patient had recovery of symptoms as well as improvement of near visual acuity, for which the patient had come for. So management of VMT is only if patient begs for surgery, otherwise should not. If the VMT is disturbing his day-to-day life because metamorphopsia is troubling his day-to-day working, or there is a decreased vision or associated ERM, then only I will go for surgery. And believe me, whatever anybody may say, we are treating a human eye and not a picture of OCT. And basic aim is to remove this vitreous, and it's a reasonably easy surgery. All of us are accustomed to do MIVS, but in came a decade back ocriplasmin. It came with a very big bang and went out with a bigger bang actually. I don't think so anybody uses Jetria, although this company may still propagate and a lot of trials keep happening, because the success rate with single injection of Jetria, $4,000 is only 25 to 27%, whereas MIVS guarantees success of more than 90-95% statistically. So therefore, to my thinking, Jetria has no place in the management of pure VMT at all. Because this surgery MIVS is very definitive, and after you do a core vitrectomy, go ahead and remove the vitreous, put air, that's it. We do not inject any gas or anything also. So this is one of the video which shows without any staining, but normally we stain with tricot, but in this patient we tried, and this could be successful easily, that entire vitreous could be removed like this. In this patient, we have, after doing a core vitrectomy, put in this tricot undiluted only, and I do not use that orocot tricot. We use a normal tricot only, and gradual increase in suction with your eye always on the retinal surface, and this comes out very easily, and after that you do airflow exchange, and results may take couple of months, but the metamorphopsia disappears faster than the anatomical picture on the OCT. So situation like this, I thought, is very scary, because if you do what I showed in the previous video in this patient, likelihood is that you will induce a iatrogenic macular hole. So in such situation, you have to be slightly more careful. What happened? So in such situations, as Dr. Bhuvan was saying, we do a foveal sparing PVD induction, meaning thereby you go round and round after you have separated the plane. Then don't pull at the fovea and leave a small island as is being shown here. We trim all around, but this small stump is allowed to remain there. And then you complete the peripheral vitrectomy and inject air only. So this was the same patient pre-op OCT and then post-op. The contour definitely will come back as long as you have relieved the traction. So there's no need to pull and leave that stump there only. So this is another example of alarming VMT. 3 by 60, no PVD, complete PVD done, only hyaloid trimming was done and left the stem. No ILM peeling also. And patient had a nice foveal contour. Thanks to these 3 lines which are functioning here, including ELM and ISOS junction RPE, good recovery. The other condition is epiretinal membrane. I will not be touching macular hole. And epiretinal membrane can easily be diagnosed, on OCT, because it is more refractile than the hyaloid. But again, all ERMs don't require surgery. All ERMs, this patient is asymptomatic. Only we alarmed this patient that you have a abnormality. Patient is not aware also. This patient went for cataract surgery, but otherwise patient had no symptoms at all except for mild blurring of vision because of cataract. And other thing is ILM peel, although ILM, we have all become ILM addicts, that we want to peel ILM in all patient detachment, but it's not necessarily required in patients of epiretinal membrane, because in the pathology of epiretinal membrane, it is epi means upon the retina, whereas ILM is definitely part of retina. And even if you see global trends, there's no advantage of removing. The only advantage of ILM peel is that it ensures that all membranes have been removed in front of the ILM. So this was a patient who had epiretinal membrane and a attempt at lamellar hole formation also. But see, all these 3 lines are very nicely, anatomically present. So we did this surgery initially, where hyaloid induction was done with the help of cutter only, and this came out very nicely. After this, how I try to remove epiretinal membrane is I will do an airflow exchange, and under air I'll put 1 or 2 drops of trypan blue. So wait for a minute or so. After that, under air, I will remove this excess dye from the. Then this instrument which I am very fond of is the bent MVR blade or 25 gauge MVR blade, which is then tried to create a plane. I am not a very fond user of diamond duster in such conditions, because I think that is more traumatic than this. And then once you identified the plane between the healthy and the unhealthy retina, that is epiretinal membrane, then catch hold of this with the help of forceps and take it all around. Go to the base after immediately, after every step, go to the base again and again. Otherwise, And I saw the condition of the macula. It was a lamellar macular hole. So in this patient, I injected third dye, that is now the BBG, and the entire ILM could be peeled off. I did not create ILM flap in this situation. I peeled off the entire ILM here. And this, all the three membranes, hyaloid, epidermal membrane, and ILM, they came out nicely in this patient. And so was the result also. This was the preoperative picture 6/24, and this is after a couple of months. It takes a couple of months to restore the anatomy. And fortunate for me and patient also, patient recovered 6/6, and one of the very happy patient. So this video, small video, shows 3-4 kinds of pathologies, 3-4 kinds of membranes in various situations, all epiretinal membranes. So this was a bent MVR blade as a huge membrane over the disc as well as the macula, the entire posterior pole. So after identifying the edge, in fact, without the forceps also, we kept continuing, and membrane was obliging us, and it came off very nicely in this single plane with no complications to the underlying structure at all. But this, most of the times we tend to use the forceps rather than continue like this. So this was another, this is a diabetic patient. You see, after you make a hole in the hyaloid, remove the subretinal blood, then you identify all these membranes which are there on the surface of retina. These, although they are diabetic ERMs, but the method of removal is slightly different than the routine idiopathic ERMs what we talk of. And after we cut, then we take forceps and make a plane and do it. This was a patient who had silicone oil removal done after a detachment surgery, but had a membrane. So a lot of these patients of silicone oil removal, we have to combine with the removal of the epiretinal membrane, and this generally is not a very difficult job. Sometimes you can do under the oil also, but if I have planned that oil has to be removed, then I will do it after the silicone oil has been taken out. This was another patient who had a dry ERMD. Sorry. So we'll skip to this. This was a currently young gentleman actually, who had a huge membrane. Again, similar steps: vitrectomy, hyaloid removal, under air, inject trypan blue, identify the edge, and with the help of forceps, this huge membrane was taken out. This patient already had a VR surgery done some years back, and the entire membrane comes in one go. This was again a epiretinal membrane in a relatively young patient who had a combined detachment secondary to vasculitis. You see all these vessels virtually closed, ultimately proved to be a Behçet's disease. And again, this epiretinal membrane, but I follow similar steps. Stand it under air and remove this epiretinal membrane, and then carried on the routine surgery for the detachment. So this was another patient where there is although membrane looked like a smaller membrane, but once we went inside and started doing the job, after having identified the edge, Vishal, I'll stop after this 1 minute only. So here, once we started taking it towards the fovea, the underlying retina I thought was very much adherent, and you notice this blanching of color here and reflex. So what I did was I made a cauliflower like you see this whitish reflex. So don't be aggressive. Go towards some other side and try to make it a cauliflower. And after that, instead of pulling, I brought in a cutter inside and then took off this membrane. So this here comes the cutter, and after you have made this, then it comes relatively atraumatically rather than keep pulling and pulling and pulling. These are a couple of results of patients, a obvious grade 3, grade 4 macular pucker here, and improved picture, ONOCT, as well as symptomatology also. Most of them, we do a combined cataract surgery as well as macular surgery, because don't want to give credit to the cataract surgeon always. Some credit should come to the retina person also. Thank you, Vishal. These were the couple of patients of membrane which we thought we'll share.
I think I agree with sir, especially when you have the LHEP associated with epiretinal proliferation or even the macular hole associated with epiretinal proliferation. The most important thing is we try to just peel it across.
Yeah.
It's better to bring it to the center and just trim it and then leave it. We have seen surgeons burning their fingers trying to cut it across, not recognizing that it is a epiretinal proliferation, thinking it to be a simple idiopathic ERM, and then the iatrogenic breaks have really happened. So identifying pre-operatively and then changing the technique, I think, is a good way. I really appreciate your
Absolutely,
video.
absolutely, because idiopathic ERM is a different this thing than all this secondary membranes. So you can't keep pulling the membrane without paying. Your eye always has to be on the retina.
The
And
fovea.
actually, with macular holes with epiretinal proliferation, you can actually invert that tissue inside the hole rather than trimming it also. So, and so, what is your threshold of operating VMT? The patient might have 618 vision or 612 vision, but if you close one eye, the uniocular metamorphopsia might be troubling. He's okay, he's comfortable with binocular vision. But what is the criteria? The vision, the amount of metamorphopsia, or the progression?
As I said, patient has to beg for surgery. VMT patient, I don't think vision is the criteria. 6/9 metamorphopsia we have operated, and 6/18 without metamorphopsia I have not operated. So what I'm saying is patient has to virtually ask this eye is troubled, nahi, काम नहीं होता. So then we operate. Obviously, if there is a pucker and decreased visual acuity and CME or other epiretinal membrane, then we go ahead and operate. Even, but if there is no metamorphopsia, if you are asking that, then my threshold will be, or say 6/18, 6/12.
So
But
usually,
6/9 without any complaint, I will not.
yeah. So symptomatically, patients will operate as
Symptoms
they
is the
come.
first thing. Remember that you see, we are here to help the patient. Whatever patient complaint may have, he has to ask for something. So first question, as we were taught in RP center also, CC, what is your chief complaint of the patient? So first question always taught is, what is your complaint? If complaint says headache and I discover epiretinal membrane, so I will not operate.
Role of steroids in a persisting edema after removal of you have experience of dexamethasone implants.
Yeah,
These-
I have started doing this recently, even in silicone removal eyes, once I removed silicone oil and epiretinal membrane also is removed, then I have started using dexamethasone, and what I have discovered is that you see post-op inflammation and recurrence of membranes becomes lesser. Although I do not have too much data on this, but I hope a lot of data will emerge, and it does help. It does help. I do not do IVTA, but in patients where we inject IVTA, I do not insist on complete removal. Let those crystals deliberately remain there, and then they may have anti-inflammatory effect.
Thank you so much.
Sir, I have one question.
Yes, sir.
As you said, most of the time we are doing combined surgery, cataract, and but in case of VMT,
Dr.
is
Sampath,
combined
you can-
surgery not possible? So, which surgery would you prefer to do first, cataract or vitrectomy for VMT?
What was the question? We in VMT?
Sorry, can you repeat a little loudly? Can you speak, sir?
Most of the time, combined surgery are preferred, but in case of VMT, if patient is having cataract and VMT, so which surgery would you prefer to do first, if not possible for combined surgery?
You see, if the complaint is diminution of vision, I will allow cataract surgeon to do the cataract surgery itself. If complaint is, metamorphopsia, then the issue is totally different.
Is it possible that after cataract surgery, due to
PVD may get induced, yeah. So you see, these two patients which I had shown, this was actually not after cataract surgery, but they happened spontaneously. I agree that cataract surgery itself, because of the decreased volume inside, the vitreous body itself may get shifted slightly, and you may be blessed to have induction of PVD.
Thank you, sir.
Thank you, sir.
Thank you very much.
I now invite our esteemed guest faculty from UK, Dr. V. Sampath, for his keynote address on ochreplasmin, to inject or not to inject.
Thank you, Vishal. Good afternoon to one and all. At the outset, I would just like to thank Partha and the scientific committee for humbling me with this invitation. So without much ado, I'll just start off. The question here is ochreplasmin, to inject or not to inject? I think Dr. Lalit Verma has given the answer, but I'll still proceed with my presentation. So when there is a critical level of liquefaction that occurs in the vitreous, it weakens the vitreoretinal interface, and when that weakening is sufficient, then a PVD occurs. If not, we are left with an incomplete PVD. And this adhesion, due to the incomplete PVD, may have several sequelae. One of them is vitreomacular traction. You could have a macular hole, or if it is in the periphery, you could have a retinal tear. The culprit really being incomplete PVD. If you look at this picture here, you can see that the vitreous is in close contact with the internal limiting membrane. The internal limiting membrane itself is composed mainly of collagen 4, but there are other extracellular proteins involved in the adhesion, namely laminin, fibronectin, and collagen 8. The diagnosis of VMA, VMT, and macular holes have actually tremendously improved because of advanced imaging systems such as the OCT. And at one point, we had this ocriplasmin, which came as a pharmacological option, an alternative to previous standard waitful watching strategy. The real world outcomes at that time, with careful patient selection, it demonstrated that the results were consistent with, or in some cases even better than, the pivotal studies. We all know the ocriplasmin works by liquefying the vitreous and causing the vitreoretinal separation. When 125 micrograms is injected into the human vitreous, the estimated duration of biologic activities ranges from 16 to 42 days. Gandorfer's original paper said there was no damage to the retinal morphology, although this is debatable now. But his statement might actually be true if we wait for sufficient time, because whatever damage is caused to the retina is said to be reversible. Some of the studies that came in at that time, focusing on the full thickness macular holes with vitreomacular traction, we had varied sort of success rate for resolution of the VMA. If you go to the one at the bottom from the Cole Eye Institute, Singh et al. Had 2 cases where both of them, were successfully resolved. He, of course, had a third case which was taken away from the study because of the size of the macular hole being more than 400 microns. Now, Stallmans, who was part of the MIVI Trust trial, his paper showed very clearly that whatever you get at the 28-day stage will remain like that. And that's how the final outcome at 28-day stage was arrived at. Now, his paper also showed that there was more than 2-line improvement in a quarter of the patients and more than 3-line improvement seen in 1/10 at 6 months. Now, 1 year exactly after the FDA approved the ocriplasmin, we had the National Institute of Clinical Excellence, which approved ocriplasmin for the vitreomacular traction. Many surgeons jumped up with joy, and I found myself to be one amongst them. I'm going to discuss 2 cases of macular holes with you, which I treated with ocriplasmin. The first case is a 58-year-old lady with a macular hole sized 360 microns. A preoperative stage, you can see the OCT with the VMT tugging on that, leading to a macular hole. The visual acuity was 1/60. Ocriplasmin was injected, and within 4 weeks, we had good resolution of the traction, but the lips are still sort of wide apart. Visual acuity is still maintained at 1/60, but there's a huge amount of subretinal fluid. At 5 weeks, the lips are in contact with each other. Visual acuity is improved to 2/60. There is still subretinal fluid. At 3 months, that reduces a little bit, but vision has improved to be 3/60. So there was a 300% improvement in vision. Patient was happy. We were happy looking at the pictures and the vision. Now, she came back at 5 months. Vision was still maintained at 3 months. And then she comes back after 26 months, where the vision has dramatically improved to 6/12. And we find that the contour is almost restored except for some disruption at the fovea. She comes back 3 years later, and the vision has further improved to 6/9, and there's a near normal foveal architecture on the OCT. My second case is that of an 80-year-old lady with some amount of dry AMD. The macular hole measured 114 microns. Preoperative stage, the vision was 6/36. You can see the tractional element there. 2 months after the ocriplasmin, vision improved to 6/18. We are left with some amount of subretinal fluid. And at 12 months, there's near normal foveal architecture, and the vision has dramatically improved to 6/12. Of course, there is a little bit of drusen from the age-related macular degeneration. She comes back in 21 months after the ochriplasmin. Vision has further improved to 6.9, and this gets maintained at 32 months. So just to summarize, 5 months after ochriplasmin, vision has improved only to 3/60. Macular hole is closed, but there's minimal subretinal fluid. This is the first lady. 26 months from the injection, it dramatically improves to 6/12, and there's complete closure and elimination of the subretinal fluid. 36 months, further improvement, near normal foveal architecture. Second lady, 2 months after ochriplasmin, macular hole closes, there is minimal subretinal fluid, vision improves from 636 to 618. 12 months after the injection, dramatic improvement to 6/12 with elimination of the subretinal fluid. And 21 months and 32 months, we have visual acuity further improved to 6.9 with normal foveal architecture. I've used Haller's paper here to do a little bit of discussion. There are treatment differences in favor of ochriplasmin, generally observed across each subgroup of subpopulations studied. If the macular hole is less than 250 microns, they are more likely to achieve non-surgical full-thickness macular hole closure. A categoric 2-line or 3-line improvement in vision is seen if the patient is younger than 65 years or with a lower baseline visual acuity of less than 65 years. So in conclusion, our cases call into question the plausibility of the 28-day fixed day to assess the final outcome after the ochriplasmin injection, especially in the macular holes. So it's too early to decide about the results, and we need to wait for a bit longer. So these cases have elucidated the long-term positive outcome of resolution of full-thickness macular hole after treatment, where vision has improved even 3 years after the treatment. Some kind of remodeling is taking place within the retina, and therefore we really need some higher resolution imagery, which may be available in the future, which can throw further light to unravel the magic seen in similar cases. Points to ponder. It came out of the magic, like magic from the dust, but went away, declined in use, fell into disrepute, mainly because of the ill effects, darkening effects, so-called darkening effects seen in patients. But again, remember, they are temporary, and these are related to more of the ellipsoid zone, the ISOS segment changes, which become apparent in week 1 and can range anywhere up to 6 months, depending on various papers that I've reported. Further information is definitely necessary, and the Orbit, Ozone, OASIS trials which have taken place have not given us the full answer. So really, case selection is of paramount importance so as to know what responds well and what may not. Prognostic indicators, predictive factors are definitely necessary. Just for example, the pre-existing or pre-operative ellipsoid zone changes can be a prognostic factor, say for macular hole surgery. And similarly, this is what we need. Thank you for your attention.
Thank you, Dr. Sampath. Doctor, a quick question. Although I don't have much experience, I had injected in just 2 patients in University of Toronto. Patients, they come with unexplained loss of vision sometimes, and they usually say that you should not give it at the weekend. And suddenly they see a wavy kind of thing or a shaky vision. So all these kind are explained. I just wanted to know your experience of it.
I mean, I've been very lucky. I've given about 15 ochriplasmin injections, and I've had good success in 13 of them.
Okay.
And 2 of them, I didn't see much of a difference, mainly because of probably associated comorbidities like AMD, because I look after the AMD patients as well. So I might have been lucky, I must agree. But again, I think the darkening effect can be quite denerving. And I don't push them to have the ochriplasmin. I offer it as, because if you see, the cost of vitrectomy is about 12,000 pounds. The cost of Jetria is 3,000. So I tell them that there are these effects, but I also tell them that we need to be patient. If you do end up getting some kind of an ill effect, we need to be patient because those effects have been known to be reversed. So we just need to be patient.
And what's your minimum threshold for visual acuity in a case with VMT?
Good question, because I mean our visual acuities have ranged actually. I usually wait until the vision is dropped to 636, to be honest with you. I don't give it any better than 636. That is my own decision.
Is it still available in the UK?
It is available. It's been banned in the US, but it's still available in the UK. but I haven't used it for a few years now. Of course, the COVID came and disrupted the thing, but henceforth I'll go very careful on that one. I must agree.
Okay. Thank you so
Yeah,
much.
Thank you.
we have a question
Yeah.
from the audience. Yeah.
Thanks, Sampath. What is your threshold at which you would offer vitrectomy? Say at 28 weeks, the macular hole is not closed. So how long do you wait before you decide you're going and intervening surgically?
Okay, so I mean, if you look at the OSS and the the trial OSS especially, across these trials they found differences. They in fact found the rates of retinal detachment and things like that to be much higher in vitrectomized patients than the octoplasmy. So, I mean, that may not answer your question completely. I probably don't know. Given the disrepute that it has fallen into, I think one needs to be careful. But the explanation to the patient preoperatively, I think, is of paramount importance.
Thank you.
Thank you.
So I'll be speaking next on myopic tractional foviochiasis, some management pearls, some tips and tricks in the surgical part. I have no financial interest in any of the products used. So just a brief, pathological myopia is by definition globe elongation and a refractive error of at least 8 diopters or axial length of greater than 26.5 mm associated with the degenerative changes in the retina. And uh, as you might know, pathological myopia has a high disease burden, almost 30 to 40% of patients having more than minus 8 diopters of myopia have myopic foviochiasis, and excessive uh, axial elongation results in mechanical stretching and thinning of the choroid, leading to staphylomas, RP atrophy, LACA cracks, CNVM, foviochiasis, and finally myopic macular hole. So, coming directly to the surgical part. So, surgery in these cases are complicated. There is no standardized technique, and the results are suboptimal. And as routine, as you know, in difference to the routine vitrectomies, there are few unique challenges to surgeries in high myopic eyes. The first is visualization. The second is PVD induction. The length of the eyeball, because the routine instruments which we use are not meant for excellence of more than 30 millimeters. And finally, a common technique which can yield, a constant surgical results. So coming to the first point, visualization. So I have seen in my experience, and it's been reported in literature also, that a small amount of lenticular changes also create a huge amount of aberrations in these cases. So even if the patient is young and 40 or 45 and has few lenticular changes, it's always good to do a combined case or in a stage procedure, whether you're comfortable in a stage or combined, but do a phaco-vitrectomy and do the peeling part or the vitrectomy part at a later stage. It gives you a very crisp contrast to the already poor contrast of the choroid, and you can peel the ILM in a more confident way. So the first thing is, if there is a slightest amount of cataract in these patients, you do a phaco-vitrectomy or do a stage procedure in these cases. The second part is PVD induction. So as we all know, there is vitreochiasis in these cases, and the axial length is long, and so it's not a routine PVD induction as we do in normal eyes. So the first way of doing is to categorize whether it is less than 30 mm or more than 30 mm. So if its eyes are around 28 to 29 mm of axial length, you can just do a core vitrectomy, inject PFCL, and do a PVD induction with the help of ILM forceps. You can inject more PFCL in the well you have made. So this is, I'm doing a bimanual technique, and enlarging that cleavage plane with the blunt end of the endolite. We have used a lot of this technique in pediatric cases also, and it works wonderfully well in these cases also, because this hyaloid is actually very stuck to the retina, and it will not come out with a cutter. The second part of this technique involves patients who have axial lengths of more than 30 mm, and these eyes are really difficult. And if you inject PFCL in these cases, actually the axial length pseudo enlarges, so it's not a good idea to inject PFCL. So here the only thing is patience, patience, and patience. You use a combination of instruments. You use an end gripping forceps. You use mild section from the cutter, and in the hope and that some cleavage plane you'll get hold of, and you will induce the PVD. There's no other way around it. So you have to do it. You stain it multiple times with triamcinolone acetonide, trypan blue, and make sure that the posterior pole is stained and no amount of cortical vitreous is left at the posterior pole. The third point, the length. So there are many ways to circumvent the high axial length. You have to make posterior trocars. You can go to 4.5 mm, and you can remove the cannula part to increase your maneuverability. The most important part is using the imaging system, the viewing system. So again, if you divide it into two parts in the very high axial length of more than 30 mmHg, it's a very good idea to use a irrigating lens or a macular lens. The point here being is that in a high axial length, when you're going inside with the forceps, actually your forceps is vertical. And when your forceps is vertical, the shaft of the forceps touches the rim of the non-contact viewing system, and it can create to a lot of aberrations and jerky movements. So the macular lens provides excellent resolution and good magnification, and in these cases where the axial length is so high, you should use a magnifying lens. These are excellent things. Otherwise, you can do away with the normal non-contact wide angle systems. So we have posterior trocars, we have magnifying lenses. The other ways you can, if you are bidextrous, you can use a left hand. So the ILM was not approachable with the right hand. So in this case, I'm using my left hand to the peel ILM. So you have to use, multiple ways to come to the posterior pole with your routine instruments. Of course, there are customized forceps in my OT, which I have made to do these cases. But using all these techniques, we all know these have been described in literature, still recurrences do happen. And the primary reason is the incomplete removal of hyaloid, the proliferation, and the incomplete closure of hole. And this is a case operated somewhere else. It was operated for a high myopic macular hole or a traction maculopathy, and he developed a RD, and we operated. And you can see here, the best dye to use here is the blue dye, the trypan blue. Tricot will not stain much of the cortical vitreous. And as you can see, under the PFCL, we are peeling the ILM after the hyaloid has been removed, stained by trypan blue. And even if the retina is attached, there are frequent cases of type 2 macular hole, which is actually a suboptimal result. So what is the technique which we should follow, or which can yield relatively consistent results? So this is a case history of a patient. Is a one-eyed patient with vision of finger counting close to face, axial length is around 30, and she's a pseudophakic, and she has a myopic foveosis with a macular hole. So this is what we have been following for the past couple of years, past 3 to 4 years. And this is a small animation showing first you make the trocars around 4.5 to 5 mm E1. You will not go through the retina. The maneuverability becomes very easy. You can, with the routine instruments, you can reach the posterior pole very easy. You stain the hyaloid. There is no two ways around it. You have to have the patience in this step. You have to induce the PVD and then stain and then inject a small amount of PFCL. And the thing is that there's a lot of posterior pole fluid in these cases. So you do an inverted ILM flap technique, what you do routinely. The only difference being here is that it should be wide based. And that will, avoid you additional retinotomy to drain the posterior pole fluid. So coming to the real actually surgical video. So this was the case, and you can see the boggy posterior pole. There's a lot of fluid. There's a macular hole there. And the first step is PVD induction after making posterior ports. After that, you stain with trypan blue to see whether there is any residual cortical vitreous left or any ERM left. Once you think that there is none, you stain it with brilliant blue, multiple stainings, multiple times, and for a longer duration. You inject a small bubble of PFCL and make the posterior polar relatively flat before injecting a small bubble of PFCL, and then you start peeling. The difference here between the routine peeling, the routine inverted peeling, and the peeling in these cases is it has to be of a larger diameter. The peeling extent should encroach the excavation of the staphyloma, because you have to make the retina sufficiently redundant so that as to close the hole. If you are peeling and you have peeled a small area, it will not be pliable enough, and there will be recurrence, a late reopening of the hole, or a type 2 closure. As you can see, the extent of the peel is more than the inverted peeling in macular holes, and it's reaching that edge of the macular of the edge of the staphyloma, and that is the key to success in these cases. The second benefit of this technique, as I told you before, that you don't have to make additional retinotomy. That fluid, because of the PF seal, has shifted to the periphery. The posterior pole is flat, but by the next 2 days, the whole posterior pole will be flat. There will be no subretinal fluid, provided you have not missed any other break, any slit breaks near the vessels. And once you aspirate the PF seal, this technique is so stable, the flap is so stable, it will not get dislodged after the PF seal bubble has been removed. This is the OCT follow-up of this case. This is the fundus picture pre-op and post-op. So to conclude, lessons learned over the years are MTM is a complex surgery with varied intraoperative surprises. A thorough pre-operative workup and planning is needed. Multiple steps are useful in the surgeries, like doing a phaco-vitrectomy, doing PVD inductions with with the combination of dyes, multiple stainings for a longer time, posterior ports. But the bottom line is a thorough pre-operative counseling with a very clear communication about the chances of failure, reopening of holes, and modest improvement of vision should be done to the patient and their relatives. Thank you so much.
Yeah, thank you, Dr. Vishal, for excellent presentation and video. And they are very challenging cases of use cases. But, which are the case you feel like to operate early, or you decide on what
There's no point
criteria?
in touching these patients if they have ambulatory vision and a good navigational vision. If the only indication of surgery is a progression and a deterioration with serial OCT follow-ups, you might see a significant fluid and a significant traction in the OCT, but the patient still might be comfortable. The patient tells you, like Dr. Lalit said, that the vision has gone down and he or she is not able to do the daily activities now. Then you touch these eyes. These are complex surgeries.
And how many months you have follow up? Because many times it takes time to regress the schisis, or because your pictures is showing that in 15 days it has become flat, but in few patients it takes longer time also.
So I think if you don't have any other hole and you do the inverted ILM flap in these cases, around 6 weeks or 8 weeks, the fluid resorbs, even if the RP is very unhealthy in these cases, as it is.
Great. Yeah, sure. Thank you. Any other questions? Now I invite Dr. Srinivas to follow.
I'll invite now Dr. Srinivas Joshi from Hubli. He's a prolific VR surgeon from Karnataka, and he has a huge experience in these macular hole, different techniques of flaps and autologous retinal transplants. I'd like to request Dr. Joshi to share his experience with us too.
Thank you, Dr. Vishal, for giving this opportunity to be in your instruction course. Thank you very much, AIOS and my co-instructors. So quickly, I think this was the one technique which even Vishal was also doing it, and this is we call it as a multi-layered ILM peeling flaps. The only advantage is we have less flap dislodgement rates, as previously described by Mikulivska. So they had around 14% flap dislodgement. So this is just, I'll run through the cases. So this was the ILM being peeled in a petaloid fashion, if you can see here. After the staining, and then the only advantage is even if the one flap goes off, the rest of the flap still remains. So that's one advantage. And secondly, I will come to that in the second video, where the flap dislodgement are still less using the PFO. So this is without PFO. I'm now showing it. So here I just, once cutting it, I thought the flaps were a little larger. So I just thought of trimming the flaps with the help of the low suction and 25 gauge cut rate. Now you can see I trimmed most of it, and I now have stopped stuffing it inside the MAC hole. And now you can see this patient improved post-op. OCT shows type 1 MAC hole closure. So this is what we've been using now. We have done around 120 cases of these, and it's now due for publication. It's in the review process. So this is the large macular hole. You can see there it was more than 800 microns, and IOCT also shows just for the confirmation. And then now doing it under PFO, the advantage we have is the flaps get try to compress inside the mac hole. It gets stuffed automatically. I don't have to push it inside. So after doing that, the peeling in the petaloid fashion, I just try to stuff it inside. And now you can even see the the intra-op OCT also shows like almost it's like a closed hole kind of thing. And then the challenge here is to do a meticulous fluid air exchange, because we don't want that flaps to get dislodged. But in our experience of 105 cases, I have not seen a single case coming out. The only thing is tilt the globe a little upside so that the PFO moves out of that posterior pole, and then try to do the active fluid air exchange. So with these techniques, I have not seen any of the flap coming out, and it's showing a good result. And the post-op gas was given in this patient, and now you can see the good flap placement inside with no flap dislodgement at all. So this is the pre-op and this is the post-op pictures of this patient, and the patient had a very good visual recovery as well. Now coming to the next set is, before moving to these are the few other things. I think this was first published by Dr. Rajiv Muni. With my mentor, I learned this technique, Dr. Waiching Lam, where inducing a macular detachment induction. So here you can see I'm using a 42 gauge needle and try to inject the saline and the foot controlled slow injection. I'm just trying to inject superior, inferior and temporal. Of course, try to avoid the papillomacular bundle. So here again, the temporal side here it is lifted, and then the superior side is. So what's the advantage? The most important rationale here is to create a detachment of that 360-degree lysis of the macular edge, which probably is adhered to the RPE, and that's why these holes are not closing. So forming a bullosity like this is important because you have to detach the macular edges. So this is the pre-op and this is the post-op picture. So if you don't want to go more aggressively like neurosensory graft techniques, I think this can be tried. This also can be tried. This is another very good technique. So this was the induction of macular detachment induction. So as I said, it reduces the tension and the stiffness intrinsic to the retina, separates the tight adhesions of the retina and the RP, and 360-degree around the macular hole must ensure that the retina RP adhesions gets completely lysed. So that's very, very important here. So moving on to the next set of things here. This was a failed MAC hole, and I just thought I should first do ILM grafts. So ILM graft also works pretty well. Either you can use a viscoat and try to put it inside the MAC hole, as I'm showing here. I'll also show the other techniques later. So the only thing here is you need something for it to stay inside the MAC hole. So I use the ILM graft from a little peripheral area, temporal to the macula, to the fovea, and then try to stuff it inside the MAC hole. So I have stopped doing this technique is because sometimes inadvertently, if that metal forceps touches the RPE, then it causes scarring. So it's most of the stuffing techniques, I don't do it nowadays. Under the PFO, most of the things work really well. So this was, since it was a little large MAC hole, I had to use a little more ILM. And getting a single sheet of ILM is very, very important in these techniques. Otherwise, you have to keep on doing it and again, and sometimes inadvertently, there is a high possibility that we touch the RP here. So here, as you can see, the viscoat is holding these flaps pretty well. The flaps are also shown on the intra-op OCTs, and meticulous fluid air exchange, because these are the free flaps. So we don't want these free flaps to come out while doing a fluid air exchange. So again, tilting it and bringing it superiorly and trying to do that as I showed, and then finally go at the disc area. And the patient improved from 660 to 69 with type 1 MAC hole closure in this case. So coming to the next set is when everything fails. So and most of these procedure fails. The only procedure left is to do a neurosensory graft technique. So here you can see I'm just trying to did a cautery around the retina because I don't want to have the bleeding. I created a small blister using a 38 gauge needle, try to lift it, because while cutting that flap, we have to make sure that we don't cut the RP or the choroid. Otherwise, it causes more bleeding. So I'm just trying to lift it and then cut it. This is done bimanually. You can even do unimanually also. I'll show it a little later. So this is again, I thought I should put the PFO above it, but nowadays I'm trying to again do it under the PFO. So here sliding it under the PFO is more easier. And now you have to just place it nicely and then do a laser, and IOCT confirms the graft placement, and fluid air exchange is done and a silicone oil. And now you can see a good type 1 closure in this case as well. So coming to the next, this you can see a large MAC hole of more than minimum linear diameter was 1076 micron. So initially I did a vitrectomy and then PVD induction, and then try to the same way as I showed, select the area where there are less vascularity or the vessel doesn't pass across. So that kind of area you have to choose it. And again, I injected a 28 gauge needle, tried to create a small blister kind of thing, and then this is also done by manually. And so now you can see I tried placing it and putting a PFO above it, but it slipped and it came up. You can see there. Now again I remove the PFO because you can't inject it under the PFO. It's lighter, so it floats. So again I try to inject it again. Now you can see it slips again. So multiple attempts of such was happening, and then finally I got a good grip and I tried to place it under the MAC, over the MAC hole, and I thought, okay, the job is done, everything was going easy. And while doing a fluid air exchange, now you can see the graft again started getting displaced. So I was not very sure why the graft is not sitting on its place, and then I thought something I might have missed or something is going wrong. So I went ahead and tried to do it again. Then I realized that there was this vitreous wheel. So in spite of doing a primary, but again I could see that the PVD detachment was not completed. So that was probably preventing the graft to sit on the MAC hole. And finally now you can see a good graft placement, we could do it, and a fluid air exchange and a silicone oil injection was done. And this is the post-op picture, OCT picture of this patient, and having a good closure. Now coming to the next, this is another interesting case. So this was a subfoveal PFO which remained after doing a simple retinal detachment surgery. So 1 week later I thought I should remove it because it's going to cause loss of vision. There was little bit of ILM wrinkling. I thought I'll remove the ILM, but unfortunately the patient developed macular hole. And not just that, the patient when came back, she had macular hole RD as well. So here what I did was, the only this left to me was to do an ILM transplant. So here you can see I'm sliding it under the PFO. It comes pretty well under the PFO. You don't have to put much effort and it doesn't go away. Fluid air exchange was being done and I thought of placing the flap. Oh, the flaps came over the tip of that forceps. Now you cannot put it back once it comes back. And just to add to our this thing, a patient developed even choroidals also, temporal choroidal. So I had to drain the choroidals first. And now the only resort left to me was to do a neurosensory graft technique. So here again, after cautery and laser, 38 gauge needle was used. And here I am doing a unimanual surgery. Earlier I showed bimanual. This is pretty much easier, doesn't take much of effort. And now you can see how we can just slide that neurosensory graft over the MAC hole and confirm it. And then the silicone oil was injected. And this is the post-op picture. The patient luckily improved up to 624 vision in this case. In fact, I should say I was pretty much lucky. So coming to the last one or two. So this is another thing where I think I'll just skip this. Let's go to this. Yeah. So here what I did was, this was the case of RD, traumatic RD with the subretinal heme. So here what happened was everything was going fine. I thought of putting a TPA because there was a subretinal hemorrhage under the fovea. So what happened was, see the blister which had formed, thought everything, but the patient developed MAC hole later after a period of 3 to 4 weeks. So the only option left to me was to just put a PFO, stain the ILM, and then as I said the earlier, I just did a multi-layered inverse ILM peeling and tried to stuff these petals inside the MAC hole and did a meticulous fluid air exchange. And finally, you can see this is the pre-op, post-op, even the OCT and the patient is doing well. So we have to be careful, especially in a traumatic subretinal hemorrhage injecting TPA, and there is a possibility that the patient might have a MAC hole as well. So it's best indicated in case of CNVM or PCV, where we don't see, even we don't know whether the trauma itself could have ensued the MAC hole, or doing an subretinal TPA, it also causes injection. So it's always better to be as much safe as possible. So thank you very much. These are the various kind of things around in the literature, and thank you for the patient listening.
Srinivas, very nice presentation and very nice videos. I just feel in one of the videos which you showed, in which there was the remnant of the vitreous which was there, and probably if that vitreous had been identified initially, probably the hole would have closed with just removal of that remnant only. You know, because I think
pretty large. It was more than 1,000.
yeah, but you know, I think the main thing which I want to just say here is probably it will not close.
It was a primary surgery.
In the primary surgery, you were doing the retinal surgery. Okay. So
since the hole size was more than 1,100 micron, so the simple ILM peel probably would not have helped.
You routinely do this for a large hole? Because I missed the initial part of your presentation.
To be very frank with you, the one of the largest I operated was 1,600. So in those cases, I think it's better to do a neurosensory graft. We have seen even good visual improvement in these kind of cases.
What is the logic of visual improvement in these cases? Because it's not integrating the...
It does get integrated. If you see the literature by Tamar Mahmood, and we have now coming up with 14 cases, we are seeing few of the layers coming back. It gets integrated as a retinal tissue, and we have seen even the visual improvement also in these kind of cases. Although the comparative cases of the same size, if we do it, we'll get a much better picture.
More comparative data is also necessary.
Yeah, I think the larger data will prove it.
1,000 also closing with, you know, as a primary case, I just want to
I totally agree. Less invasive is always better.
You can do ILM peeling and plugging of it. It is
I completely agree. First, doing a simple ILM peeling, I don't think it really works in case of 1,000. Inverse ILM peeling definitely works. If it fails, then last resort is to go in for the neurosensory graft.
Exactly. I now invite Dr. Dharmeshkar for his presentation on taut posterior hyaloid membrane. Dr. Dharmesh is from Mumbai. He's a prolific VR surgeon and a very dear friend. Dharmesh.
Sure. Yeah. Thank you, Dr. Vishal, for giving me the opportunity. And as we all know that taut posterior hyaloid membrane, Dr. Lalit Verma sir has covered quite a lot about vitreomacular tractions. Financial disclosures are none. Taut posterior hyaloid, we know it's a vitreoretina interface disease, and that may develop as a complication of diabetic maculopathy and associated with retinopathy, and we have associated serious foveal detachment, and we can be seeing membrane on OCTs. That can result in the recalcitrant macular edema, foveal detachment, and not responding to laser or any anti-VEGF therapy. In literature reviews, in the eyes with a persistent diffuse diabetic macular edema with premacular posterior hyaloid phase is unresponsive to laser or anti-VEGF. Vitrectomy with the removal of the posterior hyaloid appears to be beneficial in some cases. The careful selection of the eyes with favorable preoperative clinical characteristics is improved the surgical outcome, and many articles has also found that the RNFL thickness is very important in patient selections and criteria. And in one more article, it was shown that vitrectomy, including the removal of the ILM, leads to the expedient resolution of the macular edema and improvement of visual acuity. And there's a complete release of the tractional forces and inhibition of reproliferation of the fibrous astrocytes produced in the eyes of patients with diabetes and advanced vitreoretina interface disease of the macula. So there is a video which usually the vitreous in the diabetic vitrectomy, it is always better we do triamcinolone associated vitrectomies. And PVD induction was done. And the careful edge was lifted, and then the membrane peeling was done in circumferential way. And after the staining with the brilliant blue dye, ILM peeling was done. And at the end, the FG was done. In the second case, so many times the membranes are very adherent and it's difficult to peel as a separate. So we give triamcinolone and beryllium blue injection together and trying to find the edge, and it comes out in a pieces. We can't have like a normal macular hole ILM peeling. Again, the restaining was done to find the remaining ILM. And the peeling was done and the surgery was completed with the laser. Sure. Thank you. Thank you very much.
Excellent, Ramesh. Excellent.
Yeah.
Srinivas, you have any questions?
Any questions?
Okay.
Sure. Thank you.
Any questions from the audience? Okay, thank you all the speakers and thank you delegates for attending the session. Thank you so much.